Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Welcome back to OPG with Sadia Rees. May Allah Almighty bless this gathering with beneficial knowledge and grant us the ability to learn, understand, and apply it in our clinical practice. As Allah Pak says in Holy Quran, Rabbi zidni ilma, ay mere Rabb, mere ilme izafa farma. So let's begin today's session. This is labor module, lecture number 3, final part on assisted vaginal birth. And the previous part, we discussed the indications, the prerequisites, the vacuum extraction, forceps delivery, complications, and how to recognize the failed instrumental birth. So in today's final lecture, we'll focus on the remaining high-yield RCOG recommendation, including episiotomy, postpartum care, psychological support, counseling for future pregnancy, documentation, and finally, we'll solve 20 exam-related SBA questions to reinforce the concept. Before we begin, let's look at the primary source for today's lecture. This session is based mainly on the RCOG Green Top Number Guideline number 26 on the assisted vaginal birth, which is published on April 2020. Throughout this lecture, I'll highlight the recommendations that are particularly important for exams like FCPS MRCOG IMM and MS, while also discussing their practical application in day-to-day obstetric practice. So let's move on. First of all, before we move to today's final part, let's quickly revise what we have covered so far. In the previous lecture, we learned that the choice between vacuum and forceps should always depend on the clinical situation and the operator expertise. We also discussed that vacuum causes less maternal trauma, but has high failure rate, whereas forceps have high success rate, but associated with more maternal injury. And remember that Kylinch forceps should only be used for experienced operators that under the Odon device still investigational and is not recommended for routine clinical practice. We also highlighted some important safety points like competency before independent practice and simulation-based training and senior supervision, appropriate case selection, and performing high-risk procedures. Also, we discussed about that the right instrument, the right hand at the right time ensure the safest outcome for both mother and the baby. So now let's continue with the final part. Okay, now let's discuss a very important commonly tested topic, episiotomy during assisted vaginal birth. So when you talk about episiotomy, one of the most important questions, should every woman undergo an assisted vaginal birth receive an episiotomy? The answer is no. According to RCOG Green Top Guideline, routine episiotomy is not recommended at all for all women undergoing assisted vaginal birth. However, the guideline does recommend that the possibility of a mediolateral episiotomy should be discussed with the woman during preparation for assisted vaginal birth. This is an important part of counseling and informed consent. Now, if episiotomy is not routine, how do we decide? The decision should always be individualized based on 3 important factors. First, external factors, then the clinical circumstances, and third, the woman's preference. First, the maternal factor. For example, whether she is primary gravida, she has a rigid perineum, or has other risk factor for significant perineal trauma. Second, the clinical circumstances. For example, the type of the instrument, the urgency of the birth, the fetal size, the fetal position, and the expected difficulty of delivery. And finally, the woman's informed preference should always be taken into consideration. Let's apply this to a clinical situation. Imagine you have a multigravida with a straightforward outlet vacuum delivery and good perineal stretching. In this situation, an episiotomy may not be necessary. On the other hand, if you have a primary gravida requiring a difficult forceps delivery, the risk of severe perineal trauma is much higher, and episiotomy provide significant benefit. So the key message is very simple. We do not perform an episiotomy simply because the birth is assisted. We perform only when it is clinically indicated. So if you're asked an exam, is routine episiotomy recommended during assisted vaginal birth? Your answer should be no. Routine episiotomy is not recommended. The decision should be individualized on maternal factor, clinical circumstances, and women's preference. So now let's move to the next slide, and this slide discussed one of the very highest yield topic in assisted vaginal birth. A common misconception is that if routine episiotomy is not recommended, then it should really perform. That is not true. The key is appropriate patient selection. According to RCOG guidelines, the strongest evidence suggesting a mediolateral episiotomy is seen in primary gravida nulliparous women and in women undergoing forceps birth. Think about it logically. Why these women? A nulliparous woman has never delivered vaginally before. Her perineal tissues are usually less sensible, so the risk of extensive perineal trauma is naturally higher. Now at forceps delivery, which provides greater traction and control, but also places more pressure on the maternal soft tissues. When these two factors come together, the risk of obstetric anal sphincter injury or OSS increases significantly. So this is exactly where a properly performed mediolateral episiotomy can reduce the risk of severe third and fourth degree perineal tear. However, remember that this does not mean every primary gravida forceps delivery automatically requires an episiotomy. Clinical judgment is still essential. Okay, now let's discuss the technique. Because the favorite Viva and SBA point, the incision should be made at 60 degrees from the midline when the perineum is fully distended at crowning. Many candidates remember only the 60-degree angle but forget when it should be performed. The timing is just as important. Why 60 degrees? Any answer? Because after the baby is delivered, the perineal tissues recoil. A 60-degree incision at crowning usually yields to a final angle of around 45 degrees, which keeps the incision away from the anal sphincter and significantly reduces the risk of obstetric anal sphincter injury. If you start with only 40 or 45 degree, tissues recoil may reduce the final angle even further, allowing the tear to extend towards the anal sphincter. So always remember, cut at 60 degrees at crowning, not at the delivery, and not at 45 degree. If you're asked in exam which women drive the greatest benefit from mediolateral episiotomy, the answer should be nulliparous women undergoing forceps birth. And if you're asked at what angle should a mediolateral episiotomy should be performed, approximately 60 degree from the midline at crowning when the perineum is fully distended. Okay, now let's discuss antibiotic prophylaxis after assisted vaginal birth. Another high-yield RCOG recommendation that is frequently tested in exams. One more common misconception is that antibiotics are only required if there is a perineal tear or an episiotomy. However, RCOG recommends routine prophylactic antibiotics after assisted vaginal birth, even if there is no obvious infection. In fact, this is grade A recommendation, which means it's supported by high quality evidence. So what should we give? The recommendation is a single IV intravenous dose of amoxicillin or clavulanic acid or amoxiclav, which contains amoxicillin and clavulanic acid, administered after the assisted vaginal birth. Now you might ask, why are routine antibiotics recommended? Because assisted vaginal birth increases the risk of bacterial contamination and maternal infection with compared with spontaneous vaginal delivery. Large clinical trials have shown that giving a single IV dose of co-amoxiclav significantly reduces several important complications. These include maternal infection, perineal wound infection, wound breakdown, and also promotes better perineal healing. Am I clear so far? This is prophylaxis, not treatment. There is no recommendation for prolonged antibiotic therapy in women without the evidence of infection. Of course, if a woman has a penicillin allergy, an appropriate alternative antibiotic should be selected according to your local hospital protocol. So, if you're asked in exam what antibiotic prophylaxis is recommended after assisted vaginal birth, your answer should be a single intravenous dose of co-amoxiclav, amoxicillin plus clavulanic acid is recommended routinely after assisted vaginal birth to reduce maternal and perineal infection. This is a simple one-line SB, single best answer question, but it appears repeatedly in examination. Now let's move to the next recommendation, thromboprophylaxis after assisted vaginal birth. And it is a very common misconception among trainees is that every woman who undergoes an assisted vaginal birth should receive low molecular weight heparin. That's incorrect. According to RCOG guideline, not every woman requires thromboprophylaxis. Instead, the first step is risk assessment. Before prescribing low molecular weight heparin, every woman should be reassessed for venous thromboembolism risk factors. These include a previous history of VT or known thrombophilia, prolonged labor, which increases venous stasis, immobility, particularly after a difficult or prolonged delivery, and additional obstetric or medical risk factors such as obesity, preeclampsia, postpartum hemorrhage, sepsis, or multiple pregnancy. So remember, assisted vaginal birth alone is not an indication for low molecular weight heparin. Rather, it is a one risk factor that should be considered as part of the overall postpartum VT risk assessment. Let's take a simple clinical example. Imagine a healthy woman with an uncomplicated outlet vacuum delivery who is mobilizing well and has no additional VT risk factor. She may not require low molecular weight heparin. But another woman who has undergone a difficult forceps delivery after prolonged labor, developed a PPH and has a BMI of 38 and is temporarily immobile. The patient has multiple VT risk factors and after like required thromboprophylaxis according to the RCOG VT guideline. So always reassess the whole patient, not just the mode of delivery. So if you're asked in exam, should all women receive low molecular weight happen after assisted vaginal birth? The correct answer is no. Every woman should first undergo a postpartum VT risk assessment and thromboprophylaxis should be prescribed according to established VT guideline. This is another favorite single best answer concept because examiners want to know whether you understand risk-based management rather than routine treatment. Okay. Now let's discuss postpartum analgesia, an essential component of postnatal care after assisted vaginal birth. As obstetrician, our job does not end once the baby is delivered. Ensuring the mother's comfort and facilitating her recovery are equally important. So according to RCOG guideline, women without contraindications should routinely receive a combination of an NSAID and a paracetamol. Notice the wording without contraindication. This is important because NSAIDs are not suitable for everyone. For example, they should be avoided or used consciously in women with NSAID allergy, active peptic ulcer disease, severe renal impairment, or certain other contraindications. So always assess the patient before prescribing. Now, why is this combination recommended? Because NSAID and paracetamol, they work through different mechanisms, providing better pain control rather than either the drug alone, by reducing the need for opioid analgesics. This multimodal approach offers several important benefits. It provides better perineal pain relief, allowing the mother to sit, walk, and care for a newborn more comfortably. It provides early mobilization, which not only enhances recovery but also helps reduce the risk of complications such as venous thromboembolism. And most importantly, effective pain control improves the overall postpartum experience, making breastfeeding, bonding with the baby, and routine newborn care much easier. Let's consider a simple clinical example. A woman has undergone a forceps assisted vaginal birth with a mediolateral episiotomy. Instead of waiting until she develops severe pain, we should routinely prescribe paracetamol together with an NSAID, provided there are no contraindication. Early pain management allows her to mobilize sooner and care for a baby more comfortably. And remember, good pain control is not a luxury. It is an important part of quality postpartum care. So if you're asked in exam, what is the first line postpartum analgesia after assisted vaginal birth? Your answer should be in women without contraindication. A combination of NSAID plus paracetamol is recommended as first line postpartum analgesia. This is a very common single best answer and viva question. So remember this phrase, NSAID plus paracetamol equals first line postpartum analgesia. Am I clear so far? Okay. Now, another important aspect of postpartum management, bladder care after assisted vaginal birth. Although it is often overlooked, postpartum urinary retention is a well-recognized complication following assisted vaginal birth, particularly after forceps delivery, prolonged labor, regional analgesia, or significant perineal trauma. If it is not recognized early, it may lead to blood muscle dysfunction, recurrent urinary tract infection, and even long-term voiding problem. So prevention early detection is extremely important. According to RCOG guideline, women should first be educated about the possibility of urinary retention. They should be educated about that. Many women may not realize that difficulty passing urine after delivery is abnormal. So counseling is an essential part of postnatal care. Secondly, encourage the woman to empty her bladder as early as possible after birth. The first void is particularly important. It is not enough to simply ask whether she has passed urine. You should document both the time of the first void and the volume of the urine passed. This helps identify women who may not have emptying the bladder adequately. Now, suppose a woman complains of difficulty passing urine, passes only a small amount, or you suspect incomplete bladder emptying. What should you do? The next step is to measure the post-void residual volume. If you leave with the bladder scan or catheterization of the scanner is unavailable. a significant residual volume such as postpartum urinary retention, which should be managed promptly to prevent long-term bladder dysfunction. Let's consider a clinical example. A primary parous woman undergoes a difficult forceps delivery, and 6 hours later, she passes only 50 ml of urine and complains of suprapubic discomfort. Although she has voided, she may still have a large residual volume. In this situation, a bladder scan is essential because she may have covered urinary retention, meaning she can pass some urine but still retains a significant amount in the bladder. This is why documentation and bladder assessment are so important. So if you're asked in exam, what are the key principles of bladder care after assisted vaginal birth? Your answer should include educate the woman, encourage early bladder emptying, and document the time and volume of the first void, measure the post-void residual volume if unit tension is suspected. And remember this one-line message that early bladder assessment prevents covered urinary retention. So catheter after regional analgesia. Imagine a woman undergoing a trial of assisted vaginal birth in the OT under epidural or spinal anesthesia. After delivery, should we remove the catheter immediately? The answer is no. According to RCOG guideline, these women should have an indwelling urinary catheter left in place for at least 6 to 12 hours. Although the exact duration may vary according to local protocol. Now you may ask, why is temporary catheterization necessary? The reason is that regional anesthesia temporarily reduces the bladder sensation and reduces muscle activity. As a result, the woman may not feel the urge to void even when the bladder is becoming significantly distended. If the bladder continues to overfill without being recognized, it can lead to covered urinary retention, prolonged bladder dysfunction, urinary tract infection, delayed recovery. So temporary catheterization protects the bladder during this period of reduced sensation. Once the catheter is removed, our responsibility does not end there. We should continue to monitor the fluid balance, documenting urine output carefully. Most importantly, we must confirm that the woman is able to void satisfactorily after the catheter is removed. Simply removing the catheter is not enough. The woman should pass an adequate volume of urine without difficulty, and if she cannot void or there is suspicion of incomplete bladder emptying, further assessment is necessary. Thus, measuring the post-void residual volume. Okay. So, what is the recommendation regarding catheterization of assisted vaginal birth? The woman should have an indwelling catheter for 6 to 12 hours according to local protocol, followed by fluid balance, monitoring, and confirmation of satisfactory voiding after catheter removal. So before we move on to the next section, let's take a 1 minute to revise the most important aftercare recommendation. Let's go through them one by one. First, remember that routine episiotomy is not recommended. Every assisted vaginal birth does not require an episiotomy. The decision will always be individualized. Second, if episiotomy is indicated, it should be mediolateral episiotomy at approximately 60 degrees from the midline at crowning, and this angle is essential because it reduces the risk of obstetric anal split injury. Third, the strongest evidence supporting mediolateral episiotomy is in nulliparous women undergoing forceps, but where it significantly reduces severe perineal tears. Fourth, all women undergoing assisted vaginal birth should receive a single IV dose of comoxiclav after delivery unless contraindicated to reduce maternal and perineal infection. Fifth, do not prescribe low molecular weight heparin routinely. Every woman should first undergo a postpartum VT risk assessment, and thromboprophylaxis should be given according to established VT guideline. Six, for pain management, the first line postpartum analgesia is a combination of an NSAID and paracetamol, provided there are no contraindication. Seven, bladder care is extremely important. Encourage early bladder emptying, document the time and volume of the first void, and assess for urinary retention whenever there's clinical suspicion. And finally, in women who received regional analgesia for a trial of assisted vaginal birth, an indwelling catheter is left for 6 to 12 hours, followed by fluid balance monitoring and confirmation of satisfactory voiding after catheter removal. So if you remember just one message from this section, let it be that good aftercare is as important as a successful delivery. Effective pain control, infection prevention, bladder management, appropriate prophylaxis all contribute to a better maternal recovery and better clinical outcome. Okay. Now let's move from physical recovery to something that is equally important but often overlooked, the psychological well-being of the mother. As obstetrician, our responsibility does not end with delivering a healthy baby. We also need to ensure that the woman has a positive birth experience. Many women remember that how they were treated for far longer than they remember the actual procedure. According to RCOG guideline, 3 simple measures can significantly reduce psychological morbidity after assisted vaginal birth. The first is shared decision making. Whether the clinical situation allows, involve the woman in the decision-making process, explain why an assisted vaginal birth is recommended, discuss the available options, and obtain informed consent. When women understand what is happening and why, they are less likely to feel frightened or powerless during delivery. The second recommendation is good communication. Keep the woman informed throughout the procedure. Explain each step before you perform it. Simple statements such as, your baby is doing well, you may feel some pressure during the next contraction, or we are almost there, can greatly reduce anxiety and improve our overall birth experience. And remember that communication does not stop after the baby is born. A proper explanation after delivery is just as important as counseling beforehand. A third recommendation is positive continuous labor support. Support from skilled healthcare professional and when appropriate from the woman's chosen birth companion helps reduces stress, increases confidence, and improves the overall childbirth experience. Okay, let's consider a simple example. Imagine 2 women who both have undergone a forceps delivery. The first woman received clear explanation throughout labor, is involved in decision making, and is continuously reassured by the healthcare team. The second woman received little information and does not understand why the procedure is being performed. Although both women have the same clinical outcome, their psychological experience can be completely different. This demonstrates that good communication is the clinical intervention, not just good manners. So if you're asked an exam, how can psychological morbidity after assisted vaginal birth be reduced? Your answer should indicate 3 key points: shared decision making, good communication, and positive continuous labor support. Now, another important recommendation is that is often overlooked in busy labor wards, the postnatal review before discharge. Many doctors think that once the baby is delivered, both mother and baby are fine, the job is finished. But according to RCOG guidelines, delivery is not fully complete and the woman has been properly counseled before going home. Every woman who undergoes an assisted vaginal birth should receive a structured postnatal review. The first step is to explain why the assisted birth was needed. Many women leave the hospital without fully understanding why vacuum or forceps were applied. This uncertainty can create unnecessary anxiety and even fear of future childbirth. So explain the indication in simple language. For example, your baby heart rate was dropping, so we use forceps to deliver your baby quickly and safely. This simple explanation can make a huge difference. Secondly, review any complications that occurred during the procedure. If there was an episiotomy, a perineal tear, PPH, or a neonatal issue, explain what happened, how it was managed, and whether any further follow-up is needed. The third component is counseling for future pregnancies. Women often ask, Doctor, will this happen again? And can I have a normal delivery next time? This is perfect opportunity to reassure them and discuss future birth planning based on their individual circumstances. And finally, always give the woman an opportunity to ask questions. Sometimes the questions that matter most to the patient are very different from what we expect as doctors. A few extra minutes spent answering her concern can significantly improve her confidence and satisfaction with the birth experience. Whenever possible, this post-review should be conducted by the obstetrician who performed the assisted vaginal birth. Why? Because the clinician understands exactly why the procedure was required, what happened during delivery, and can provide the most accurate explanation and counseling. For example, if a woman undergoes a vacuum-assisted delivery because of prolonged second stage with fetal compromise, before discharge, if the doctor explains the indication, reassures her that the baby is well, discusses the episiotomy care, answer a question, and explain that this does not necessarily mean that she will require an assisted birth in future, this conversation may take only a few minutes, but it can greatly reduce anxiety and improve her confidence for future birth. So if you're asked an exam, what should be included in the postnatal review after assisted birth, your answer should include explain why assisted vaginal birth was required, review any complication, provide counseling regarding future pregnancy, and allow the woman to ask questions. And ideally, the review should be conducted by the obstetrician who performed the procedure. Okay. Not every assisted vaginal birth is experienced as traumatic. However, for some women, especially after an emergency or difficult delivery, the emotional impact may last much longer than the physical recovery. As obstetricians, we must recognize these women early and provide appropriate support. According to RCOG guideline, the first step is to offer the emotional support. Sometimes the most therapeutic intervention is simply listening. So, Simple statements such as, I understand this was a frightening experience, or let's talk about what happened, can help build that trust and reduce anxiety. Secondly, every woman should have the opportunity to discuss her birth experience in a calm and supportive environment. Allow her to ask questions and explain the events in a chronological order. Many women recover emotionally once they understand why certain decisions were made during labor. The third recommendation is often forgotten. Remember that the birth partner may also be psychologically affected. A husband or family member who witnessed an emergency instrumental birth may also experience fear, guilt, or emotional distress. So, whenever appropriate, offer support to the birth partner as well. Now, let's discuss an important exam point. Many candidates think that every woman should undergo routine psychological debriefing immediately after traumatic birth. This is incorrect. According to RCOG, do not offer routine single session high intensity psychological debriefing focused on relieving trauma. Evidence shows that this type of intervention does not prevent post-traumatic stress disorder and may actually increase emotional distress in some women. Instead, provide supportive counseling, answer questions, and arrange appropriate follow-up if symptoms persist. Let's consider another example. A woman undergoes a difficult rotational delivery and later says, I keep thinking about the delivery. I feel frightened every time I remember it. The correct response is not to force her into a formal psychological debriefing session. Instead, sit with her, listen carefully, explain what happened, answer her questions, provide reassurance, and ensure appropriate follow-up if her symptoms continue. So if you're asked an exam, how should a woman be managed after traumatic birth? Your answer should include offer emotional support, provide an opportunity to discuss the birth experience, consider the psychological well-being of the birth partner, and do not offer a routine single session high intensity psychological debriefing focused on relieving the trauma. Now, let's discuss an important follow-up point that's frequently tested in MRCOG, FCPS, and IMM exam, persistent post-traumatic stress disorder symptom after childbirth. It is completely normal for some women to feel emotional or distressed during the first few days after a difficult birth. However, if these symptoms persist, they should not be ignored. According to RCOG, if symptoms suggestive of post-traumatic stress disorder are still present 1 month after birth, the woman should be referred to an appropriate mental health professional according to NICE guideline. What symptoms should make us concerned? A woman may repeatedly relive the birth experience through distressing memories or nightmares. She may avoid talking about the delivery or refuse to return to the hospital. Some women become constantly anxious, emotionally numb, or excessively alert, making it difficult to sleep, care for the baby, or enjoy daily life. When these symptoms continue beyond 1 month, early referral is essential. Do not wait for the symptom to resolve on their own. Early assessment and appropriate psychological treatment can improve maternal well-being, strengthen mother-baby bonding, and reduce long-term psychological complications. For example, a woman underwent an emergency forceps delivery. At a 6-week postnatal visit, she says, I still have nightmares about the delivery. I cannot sleep. I keep reliving the event and I avoid discussing what happened. This is not simply normal postnatal anxiety. These persistent symptoms are highly suggestive of post-traumatic stress disorder, and the appropriate management is referral to a mental health specialist according to NICE guidelines. So, what does this mean for our next pregnancy? Many women ask before leaving the hospital, doctor, because I needed forceps vacuum, will I need another assisted delivery or cesarean section next time? The answer in most cases is no. According to RCOG guideline, women should be reassured that they have a high probability of achieving a spontaneous vaginal birth in the next pregnancy. In fact, studies show that approximately 80 to 90% of women who previously had an assisted vaginal birth will go on to have a spontaneous vaginal birth in a future pregnancy. This is a very important counseling point because many women wrongly believe that an assisted birth automatically means future deliveries will be difficult. It is our responsibility to correct this misconception. Let's consider another clinical example. A primary gravidator undergoes a vacuum-assisted delivery because of fetal distress in the second state of labor. At a 6th follow-up visit, she asked, should I book an elective cesarean section in my next pregnancy? So based on the current evidence, the current advice is no. A previous assisted vaginal birth by itself is not an indication for elective cesarean section. Most women, around 80 to 90%, will achieve a spontaneous vaginal birth in their next pregnancy. Of course, every future pregnancy should be assessed individually. If new obstetric complication develops, such as placenta previa, breach, or a previous uterine rupture, the delivery plan will change accordingly. However, a previous assisted vaginal birth alone is not a reason to recommend an elective cesarean section. So, if the question is asked, how do you counsel a woman regarding future pregnancies? Your answer should include reassure her. The spontaneous vaginal birth is highly likely in the next pregnancy. Approximately 80 to 90% achieve spontaneous vaginal birth. And previous assisted vaginal birth alone is not an indication for elective C-section. Future counseling should always be individualized. While most women can be reassured about a future spontaneous vaginal birth, not every woman should receive the same counseling. Some women require individualized future birth counseling. According to RCOG, counseling should be tailored for women who have experienced a third-degree perineal tear, a fourth-degree perineal tear, or persistent pelvic floor morbidity such as ongoing fecal incontinence or urinary incontinence, pelvic pain, or sexual dysfunction. These women require a more personalized discussion because the decision for the next birth involves balancing the benefits and risk of vaginal birth against C-section. So the first point to discuss is the risk of recurrence. Explain that another vaginal birth may carry a risk of recurrent obstetric anesthesia injury or worsening of existing pelvic floor symptom. The second discussion is about the mode of birth. There's no single recommendation for every woman. Some women may safely choose another vaginal birth, but other, particularly those with persistent symptoms or significant sphincter damage, will decide that an elective C-section is the better option. The decision should always be shared, evidence-based, and individualized. And the third discussion focuses on future pelvic floor health. Explain how future childbirth may affect continence, bowel function, sexual function, overall quality of life. This allows the woman to make a truly informed decision based on her own priorities and expectations. Let's just consider another example. A woman sustained a 4-degree perineal tear during the first forceps delivery. 1 year later, she still experiences fecal urgency and occasional incontinence. She becomes pregnant again and asks, should I try for another vaginal delivery? The current response is not to give a universal recommendation. Instead, discuss her current symptom, assess the severity of her pelvic floor dysfunction, explain the risk of recurrence, review the advantages and disadvantages of both the vaginal birth and elective C-section, and make the decision together with the woman. So if you're asked in exam which women require individualized counseling regarding future birth after assisted vaginal birth, your answer should include women with third or fourth degree perineal tear, women with persistent pelvic floor morbidity, discuss the recurrence risk, future mode of birth, and long-term pelvic floor health, and counseling should be women-centered, empathetic, and based on shared decision-making. Now we have reached the final clinical responsibilities after assisted vaginal birth. Delivering the baby safely is only the part of good obstetric practice. What you document, how you report complications, and how honestly you communicate with the patient are equally important. Let's discuss these three components one by one. First is documentation. Remember the simple procedure. Simple principle. If it is not documented, it is assumed it was not done. Documentation should be complete, accurate, and standardized. According to RCOG guideline, first, the assessment. Document the maternal and fetal condition and indication for assisted vaginal birth. Second, the decision making. Record the options discussed with the woman, the counseling provided, and the reason why vacuum or forceps was chosen. Third, the conduct of the procedure. Mention the instrument used, cup or forceps type, station and position of the fetal head, number of pulls, any cup detachments or difficulties encountered, and the final outcome. Next, document the postnatal care plan, including maternal observations, medications, analgesia, bladder care, thromboprophylaxis if indicated, and follow-up arrangements. And also record the future pregnancy counseling, especially if there was obstetric anesthesia injury or any significant pelvic floor injury. And finally, remember another high-yield point, paired umbilical cord samples should be also be documented and recorded when indicated. Good documentation protects the patient, improves communication within the healthcare team, and provides important medical legal protection. Remember this. Second, incident reporting. Not every complication represents poor care, but every significant complication should be reported appropriately. For example, if failed instrumental birth or major PPH or obstetric anesthesia injury or shoulder dystocia or significant neonatal complication, why is reporting so important? Not to blame individuals, but to improve the healthcare system. Incident reporting supports the clinical governance, risk management, patient safety, future learning, quality improvement. So every serious adverse event is an opportunity to learn, and prevent similar events in the future. And finally, duty of contour. This is an important professional ethical responsibility. If something goes wrong during delivery, be open, be honest, be compassionate. Explain clearly what happened, why it happened, and what has been done to manage the situation. Use language that the woman and her family can easily understand. Do not hide complications or avoid difficult conversations. If a serious adverse event occurred, report it promptly according to local policy. Participate in clinical audits and confidential inquiries because these help improve patient safety in future obstetric care. The goal is not to assign blame, but to learn from complication and continuously improve practice. This example, imagine a forceps delivery complicated by third-degree tear. After repairing the tear, the obstetrician carefully documents the indication of a forceps, details of the procedure, repair performed, counseling giving. The complications reported through the hospital incident reporting system. Before discharge, the woman is informed honestly about the injury, reassured regarding the treatment, counseled about the follow-up and future pregnancy. It is an excellent example of good clinical governance and professional practice. So if you're asked in exam what should be done after assisted vaginal birth regarding documentation and governance, your answer should include complete, accurate, and standardized documentation, report serious adverse event through the appropriate incident reporting system, follow the duty of contour by being open, honest, and compassionate, participate in audit and quality improvement activities, and learn from complications to improve from patient care. So now we have completed the assisted vaginal birth lecture. Let's finish by reviewing the 8 high-yield exam pearls that you should remember for your viva, structured discussion, and single best answer examination. First, shared decision making. It reduces the psychological morbidity. And second, every woman should receive a proper postnatal brief before discharge, including explanation of why assisted vaginal birth was required, any complication, and counseling for future pregnancy. Third, a post-traumatic stress disorder persists beyond 1 month, refer the woman to mental health professional according to NICE guideline. Fourth, reassure the woman that approximately 80 to 90% will achieve a spontaneous vaginal birth in their next pregnancy. A previous assisted vaginal birth is not an indication for elective C-section. Then, individualize the counseling after OBS and sphincter injury and pelvic floor injury. Six, documentation must always be complete, accurate, and standardized. And then, 7, major adverse events should be reported promptly to support clinical governance, learning, and patient safety. And be honest, transparent, and compassionate and follow the duty of contour. So, finally, we have completed the lecture. Now, take a pause, have a deep breath, and let's do a quick brainstorming session. Remember, in your exam, examiners are not simply testing your memory, they are testing how you think. So, a good doctor does not just recall the guideline, a good doctor applies them to real clinical scenarios. So from this point onward, I want you to think like the obstetrician on duty. Imagine you're standing in the labor room, patient arrives, CTG changes, fetal lattice low, consultant asks, what will you do next? That's exactly how you will feel your exam. So in this session, I don't want you to rush to the answer. I instead ask yourself, why am I choosing this option? What guideline supports my decision? And what is the safest management for both the mother and the baby? And my first plan is, what is my backup plan? So that's the difference between memorizing medicine and understanding medicine. So our goal is very simple, not just to pass exam, but to become the doctors who make safe, evidence-based decision and with confidence. So keep your notebooks ready. Think before you answer, challenge yourself, and let's start brainstorming. So, question number 1 is a primigravida at full dilatation requires vacuum assisted birth. During traction, there's no progressive descent. Despite moderate traction with a correctly applied cup, what is the next step? So, pause the video and choose your answer. Number A, continue with stronger traction. Number B, attempt 3 more pulls. Number C, discontinue vacuum assisted birth. D, rotate the cup. E, apply forceps immediately. According to RCOG Green Top guideline, if there's no progressive descent despite adequate traction with a completely applied cup, the procedure should be abandoned. Continuing with stronger traction or repeated pulls only increases the risk of maternal trauma and neonatal injury. Likewise, immediately switching to forceps is not recommended as sequential use of instrument. is associated with higher complication rate. So the answer is C. Okay. Now let's move to SBA number 2. According to RCOG, successful vacuum birth is usually completed using A, 2 pulls, B, 3 pulls to delivery, C, 3 pulls to perineum, followed by up to 3 gentle pulls. 5 pulls, unlimited pull placenta occurs. 3 pulls to the perineum, followed by up to 3 gentle pulls. RCOG Green Top Guideline recommends that vacuum delivery should be complicated with 3 pulls to perineum. After that, up to 3 gentle pulls may be used to achieve delivery. And if there's no progress after 2 pulls, reassess and consider abandoning the procedure. Why other options are wrong? 2 pulls insufficient, 3 pulls delivery not sufficient if head is not in perineum, 5 pulls exceeds the recommended limit. इसको तो करना ही नहीं है. Okay, after the first 2 vacuum pulls, there's minimal descent with diagnosis should not be immediately considered. Incorrect cup placement, yes. Wrong fetal position, yes. CPD, yes. Placenta previa, no. Need for reassessment, yes. Placenta previa does not cause poor descent during instrumental birth and is not a cause to consider at this stage. Okay, vacuum extraction should generally be abundant. A, 1 pop-off, B, 2 pop-offs, C, 3 pop-offs, and D, 4 pop-offs, and E, 5 pop-offs. Okay, the key is 3 pop-offs. I want to consider it. What say? Should we? Why am I considering it? See, according to RCOG guideline, vacuum extraction should be abandoned after 2 pop-offs, है ना? A maximum of 3 pop-offs is limit. So I will go for 2 pop-offs, है ना? It should be abandoned about 2 pop-offs. The 3 pop-off limit है. We can discuss it. You can discuss in the comment box. So although 3 pop-off represent the absolute maximum limit, the recommendation is not to continue after 2 because repeated cup detachments are associated with significantly high risk of neutral complications, including scalp trauma, cephalohematoma, and subleal hemorrhage. Okay. Following a failed vacuum birth, the obstetrician should first A, send mother home, no. B, inform the neonatologist. C, start the antibiotics. D, perform MRI. E, discharge the baby. And C, and okay, what should be the key? Send mother home, no. But B, inform the neonatologist may be needed later, but not the first priority. C, start antibiotic. Yes, it increases the risk of significant maternal genital tract and trauma infection. So it recommends that you should start the antibiotic. Although it is a weak stem, I think so. Yeah, because in my opinion, it should be from the neonatologist and start antibiotics both. But if you ask me which should be the first, so it should be C. Give broad-spectrum antibiotics, then reassess the mother and plan the next appropriate step. Okay. Sequential use of vacuum followed by forceps is associated with. Pause the video and choose your answer. A, lower maternal trauma. B, reduced neonatal injury. C, increased neonatal trauma. D, better vaginal birth rate without complication. E, no difference. Increased neonatal trauma. Sequential use of instrument where a failed vacuum is followed by forceps is associated with significantly high rate of neonatal injury, including scalp trauma, cephalohematoma, intracranial hemorrhage, facial nerve palsy. So according to RCOG, if a vacuum attempt is unsuccessful, it should be abandoned and an alternative mode of delivery with cesarean section should be considered rather than switching to another playing with the patient. Okay. Which statement regarding forceps is correct? A, continue until delivery regardless of pull. B, stop if the blades cannot be applied easily. C, apply the 3 pop-off rule. D, use excessive traction. E, forceps always required an episiotomy. I think it's, you should pause the video, think about your answer. The correct answer is B, stop if the blades cannot be applied easily. Forceps should be applied gently and without undue force. If the blades cannot be positioned easily, forcing the application, increasing the risk of maternal trauma, fetal injury, and a failed operative vaginal birth. So in this situation, the operator should stop, reassess diagnosis, fetal position, station of pelvic adequacy, and consider an alternative mode of delivery. Okay. Birth is not imminent after 3 pulls with correctly applied forceps. What is the management? Continue traction, change the operator only, discontinue forceps, increase traction, switch immediately to vacuum. The correct answer is discontinue forceps. Why continue traction? It is unsafe. And why change the operator? It does not address the problem. It is not recommended. Discontinue forceps. And increase traction, it is dangerous, and switch immediately to vacuum. Incorrect. Once forceps are applied, do not switch to vacuum. I told it previously. Okay. Minimal descent after the first two forceps should make you suspect all except CPD, incorrect application, wrong fetal position, placental abruption, and need for reassessment. Yes, placental abruption, as if there is minimal or no descent after two forceps, think about problems related to mechanics of delivery, such as incorrect forceps application, wrong fetal position, CPD, or the need for immediate reassessment of the passage, position, contraction, bladder, and technique. Placental abruption is not a cause of poor descent during operative vaginal birth. Instead, it typically presents vaginal bleeding, abdominal pain, uterine tenderness, and fetal distress. Following failed forceps birth requiring C-section, obstetrician should anticipate placenta accreta, impacted fetal head, cord prolapse, uterine inversion, and shoulder dystocia, impacted fetal head. After failed forceps delivery, especially with difficult traction or in deep engagement, the fetal head will become impacted. So it makes C-section technically more difficult. Accreta is not related to failed forceps, and cord prolapse is rare after engagement, not a direct consequence. And uterine inversion is very rare due to fundal pressure. And shoulder dystocia occurs during delivery of the shoulders, not after failed forceps. Routine episiotomy during assisted vaginal birth is recommended for everyone? No. Recommended only for vacuum? No. Not routine recommended? Yes. We have discussed it. Mandatory for multiparous women? No, please. Contraindicated. Which woman drive the strongest evidence-based benefit from mediolateral episiotomy? As I told Ray, multiparous vacuum birth? No. Nulliparous forceps birth. Elective C-section? VBAC during pregnancy. RCOG recommends that routine episiotomy should not be performed during assisted vaginal birth. अगर करना है mediolateral episiotomy में, तो the strongest is nulliparous women undergoing forceps birth, which significantly reduces the risk of OBS and sphincter injury. A correctly applied or performed mediolateral episiotomy should be made at for 30 degree, 45 degree, 60 degree, 75 degree, 90 degree. According to RCOG, mediolateral episiotomy should be initiated approximately 60 degree with later stretches to 45 degree, helping minimizing the risk of OBS and sphincter injury. So the answer is C. Routine antibiotic prophylaxis after assisted vaginal birth consists of oral amoxicillin, B, IV ceftriaxone, no, single IV amoxicillin, which consists of amoxicillin plus clavulanic acid, yes, oral metronidazole, and no antibiotics. Okay. Regarding thromboprophylaxis after assisted vaginal birth, no. Molecular weight happen for everyone, no. Only after forceps, no. Risk assessment before prescribing, yes. Only after vacuum, no, never indicated. According to RCOG, every woman should undergo an individual VT risk assessment. Assisted vaginal birth is a risk factor, but it is not an indication for low molecular weight heparin itself. First and postpartum analgesia after assisted vaginal birth is morphine, NSAID plus paracetamol, tramadol, codeine, gabapentin. The correct answer is B, NSAID plus paracetamol. And according to RCOG and NICE guideline, the first line treatment for pain after assisted vaginal birth is a combination of NSAIDs such as ibuprofen together with paracetamol, and this combination provides excellent relief for perineal pain and uterine cramping. It is opioid sparing, compatible with breastfeeding, and has a better safety profile. Okay. Women who received regional anesthesia for trial of assisted vaginal birth should usually have immediate catheter removal, indwelling catheter for 6 to 12 hours, suprapubic catheter, no bladder monitoring, intermittent catheter. The correct answer is B, indwelling catheter for 6 to 12 hours. Regional analgesia, including epidural and spinal anesthesia, reduces bladder sensation and increases the risk of postpartum urinary retention. Therefore, RCOG recommends leaving an indwelling urinary catheter for approximately 6 to 12 hours postpartum or until bladder function has been fully returned. After the catheter removal, monitor the woman carefully to ensure that she is able to void normally and she has no evidence of urinary retention. Persistent post-traumatic stress disorder symptom following assisted vaginal birth should form referral after 1 week, 2 week, 1 month, 3 months, 6 months. Pause the video and choose your answer. The correct answer is C, 1 month. Women should be reassessed after traumatic birth experience and offered emotional support. However, according to RCOG, post-traumatic stress disorder persists beyond 1 month postpartum. They should be referred for specialist psychological assessment and treatment. Women with a previous uncomplicated assisted vaginal birth should be counseled that a spontaneous vaginal birth in the next pregnancy occurs in approximately A, 30%, B, 50%, C, 60%, D, 80 to 90%, E, less than 10%. The correct answer is G, 80 to 90%, and evidence shows that women who have had a previous uncomplicated forceps or vacuum delivery have an excellent chance of achieving a spontaneous vaginal birth in the next pregnancy. Past success is the best predictor of future pregnancy. Approximately 80 to 90% will have a spontaneous vaginal birth. Finally, let's discuss the single best answer number 20, which of the following is recommended as a part of documentation after assisted vaginal birth. A, procedure details only. B, maternal observations only. C, assessment, decision making, procedure details, postnatal plan, counseling, and peer cord sample. Obviously, the key is C. According to RCOG, documentation after assisted vaginal birth should be comprehensive and accurate and should include the maternal and fetal assessment, the indication for procedure, informed consent, details of the procedure, what instruments were used, any complication, maternal observation, neonatal outcome, post-natal management plan, peer cord sample were indicated according to local policy. So, congratulations, you have successfully completed the assisted vaginal birth lecture series. Throughout the series, we have covered everything you need for the exam for MRCOG, FCPS, IMM, MS, and day-to-day clinical practice from classification, prerequisites, vacuum, forceps, complications, failed instrumental birth, episiotomy, postpartum care, documentation, and very high-yield single best answer questions. But remember, the most important message is this: a successful vaginal birth is not about completing the delivery at all cost. It's about selecting the right patient, using the right instrument, applying the correct technique, recognizing when to stop, and always prioritizing the safety of both the mother and the baby. And I hope the series has strengthened your concepts and increased your confidence in both examination and clinical practice. But thank you once again for completing the Assisted Vaginal Birth series. But our labor module does not stop here. In the next lecture, we'll cover one of the most important topics in modern obstetrics, vaginal birth after cesarean section. In this evidence-based session, you will learn who is eligible for VBAC, success predictors, and contraindications, VBAC versus selective repeat cesarean section, intrapartum management and fetal monitoring, induction augmentation of labor, early cognition management of uterine rupture, counseling, informed consent, and shared decision making, high-yield RCOG and NICE recommendation, as always. 20 exam focus, single best answer for FCPS, MRCOG, IMM, and MS. And if you're preparing for postgraduate exam and want to practice evidence-based obstetrics, this is one lecture you don't want to miss. So make sure you're subscribed, turn on notification. I'll see you in the next lecture on VBAC. I'm Dr. Sadet Rees, and I'll see you in the next evidence-based lecture. Until that, keep learning, keep practicing, and stay safe. Allah Hafiz.